Good morning. Ceylon College of Physicians is the apex body and apex professional college which pioneered the development of field of geriatric medicine in Sri Lanka. Today, I would like to introduce Prof. Andrew Elder, a speaker for the first plenary. Is a well-known personality to us. He is the first geriatrician to serve as the president of Royal College of Physicians, Edinburgh, and the director of MRCP PACES from 2013 to 2018, which MRCP PACES Colombo was inaugurated. Prof. Elder will talk to us on equity in care of older people, which will be a timely topic as Sri Lanka has the fastest aging population in the South Asia. Over to you, sir.
Well, thank you very much. Good morning, everybody. Thanks for the introduction and the invitation to come. Although I'm a geriatrician, I don't these days often talk about issues relating to the care of older people. But when I saw your theme this year of diversity, inclusivity and equity, I thought I should speak about an issue relating to older people, and that is essentially age discrimination, or what you might call ageism in the care of older people. I have no financial or commercial interest in relation to the content of this talk. I usually start with thanks, and I would thank all my colleagues for, in fact, all the talks I give, they have some relevance. So my thanks to all the people I've worked with at these various places, particularly in recent years. I'd also thank ChatGPT. We all play around with ChatGPT, don't we, these days? And those two images are what you get if you type in, can you create an image of an older person in Sri Lanka for me? And this is what you get if you type in, can you create an image of an audience of Sri Lankan doctors looking enthralled at a talk on age discrimination, seen from my views. And I guess, you know, it does look something like that. But the other thing that slide reveals, and perhaps Dr. Patel, who's following me, will touch on this, is the what's called automated discrimination that's built in to large language models like ChatGPT. Because you can see that the audience is predominantly male. Okay, so even our AI is discriminatory. And as I say, that's the theme of my talk. So how am I going to do this? Well, I'm going to be quite quick. I'm going to give you some reminders about older people. I'm just going to go through several definitions, a couple of the many theories about why ageism actually happens, and then I'll run through some of the different forms of ageism that we encounter in healthcare. I won't give you solutions. I hope the solutions become apparent when you look at the list of types of ageism that happen. Okay, so some reminders. First of all, there is Sri Lanka's changing demography. And isn't it remarkable, if you look at 1961 there, the classic pyramid-shaped demography with very few very old people and very many very young people, shifting there to that almost columnar, vaguely Taj Mahalish there in 2021 with the population doubling, but the over 65s doubling as well. But look at 2051. It is almost a column all the way up there. And in 2051, in fact, before then, Sri Lanka will become what's called a super-aged country. You get classified as super-aged when when you have more than 21% of your population over the age of 65. So Sri Lanka has to start to think about how it's going to shift its health care to cope for that changing demography, for more and more older people. As I said yesterday when in my guest of honor remarks, we sometimes seem to forget that change in demography is actually a societal triumph. Yeah. It's not largely down to doctors and to medicine, it's down to improvements in socioeconomic conditions. But we're at risk of, I would say, of converting this triumph into a disaster if we do not adjust our health care to care for older people. The second reminder is this, and I got this quote when I was giving talks in India about older people. Very often the old are portrayed as a burden, as passengers in society because they may not be economically contributing to society. But look at the little list of things in that paragraph there that older people do. Grandparenting, volunteering, caring still. I like the resolving conflict and offering counsel. So the old do add much to our societies, and we shouldn't think that just because they are not economically contributing to society that they aren't. And my final reminder is this one that's well known to you. Using the number after our names, our age and years, can be very, very misleading. It's much better to try and classify people, if we're going to classify them, according to their function, okay? Because your age alone doesn't tell you everything about the person. And here's Fauja Singh. That picture's actually in Edinburgh a good few years ago now. But he ran the marathon in 5 hours 40 when he was 92. And that is faster than I could do right now, I think. And I'm still, thankfully, significantly younger than him. Okay, a few definitions then. Well, how would we define ageism? And I think that it probably is, when you think about it, the last acceptable prejudice. We talk much more about all the other prejudices, sexism, racism, but somehow ageism is pushed into the background. There's Butler's original definition for you. Stereotypes, discrimination against older people. And of course, stereotypes, prejudice, and discrimination are all subtly different. Stereotypes are how we think. So a stereotype of the Scotsman, me, my bit of stereotyping. Prejudices are how we feel when we encounter somebody who we have a stereotype about. And discrimination is how we all act in response to those prejudices. And it's worth remembering that we can direct those prejudices either against others or indeed against ourselves. And that's one of the very interesting things about ageism. I'll show you a little bit about that later on. Ageism, of course, can be applied to younger people. All I'm going to talk about today, though, is prejudice against the old. Another definition, the difference between direct and indirect age discrimination. A very, very simple and obvious example would be direct discrimination would be if you said that only people under the age of 80 can have a hip replacement. That would be direct age discrimination. If, on the other hand, you said, well, you're not going to get a hip replacement unless you're out of the hospital within 7 days, that would disproportionately target older people. And therefore would be an example of indirect age discrimination. I say all that largely because it can be much more difficult to see and recognize indirect age discrimination than it is to recognize direct. Another definition that's important to think about is the difference between equality and equity. And this is this very, very well-known internet cartoon that has more than 2 boxes to it. But it does make a useful point. The idea of equality here is that everybody, all these 3 individuals in their attempt to see the game of cricket or baseball, are given the same opportunity. They're given a box of the same size. But one of them still doesn't get the outcome which is intended, which is to be able to see the game. Equity, the idea of equity relates to outcome. So you may have to do more for different people to enable them to get the same outcome, okay? And in healthcare, that idea broadly is sometimes called proportionate universality, that you try and do everything for everybody, but you may have to do more for some people to get them to the same outcome. Now, one caveat there with regard to the care of older people is that we can strive towards equity of access to health care. So we can say, whatever your age, you should be able to be assessed or be given a particular type of health care. But simply because of biology, we can't guarantee equity of outcome. In other words, survival following coronary artery bypass surgery will never be exactly the same for 80-year-olds as it is for 60-year-olds, okay? so we can make sure everybody is able to access the procedure, but outcome may not be the same. Another definition worth remembering is a concept is the idea of intersectionality. We're all unique individuals made up of a number, I guess, of protected characteristics that I list there in the little cartoon on the left. I won't go through them all. Race, ethnicity, gender, class, etc. But discrimination, and not just relating to the old, it can relate to a combination of these different protected characteristics. So if we think about, for example, the level of discrimination an 85-year-old may face, it almost certainly will increase if it's an 85-year-old female. It will increase more if it's an 85-year-old female from an ethnic or religious minority. And it will increase even more when it's an 85-year-old female who's poor from an ethnic and religious minority. So I say all that really just to stress the notion that we are all unique, and we need to think about the specific discrimination that each individual may face. Okay, so that was my reminders, some definitions, a couple of theories now about why ageism happens. And I think it is a very interesting prejudice because, as Butler said, it's actually, most prejudices are directed clearly against groups of others, yeah? But ageism can be seen as a prejudice against your future self, because we're all hopefully going to get old. Or maybe more than that, against your feared future self. Excuse me. One of the most interesting psychological theories of old ageism relates to this idea that humans are thought to be the only sentient beings who are aware of the fact that they're going to die. You know, your cat or your dog does not know it's going to die. Aging brings proximity to death in our eyes, and we therefore respond to that image of the old person with avoidance. And the whole psychological theory around that is called terror management theory, and I'll just show you one slide about that. If you want to know more about it, the book I've shown you there at the bottom called The Worm at the Core. The worm at the core is the idea of death gnawing away at us, and we try and push it into the background. But that summarizes all the research that there is on this idea of terror management theory. And that theory focuses on the idea of what's called mortality salience, and that is that we are aware of our own death. And in a number of different experiments, and I'm just quoting you one because it's quite remarkable, really, that if you're reminded of the fact that you're going to die before you're asked to make a decision about something, your decision changes. So in this quite interesting example, people who were reminded of the fact they were going to die were more likely to buy BMWs than they would have been had they not been reminded that they were going to die. Now, I know you think, well, how does that relate to ageism? But the point simply is that the presentation of that information to us influences our behavior. And if we accept that, we could see that being presented with an older person, which is a mortality salience prompt, might influence our behavior in some ways. So that's broadly probably the major psychological theory of why ageism might happen. The second, I guess, group of theories are what I would call pragmatic or rational theories, and relating to concepts like the good old cricketing fair innings, and that in healthcare it's perfectly reasonable to expend limited resources on the young because they're our future, rather than the old because they're our past. Okay, so you can see some reasoning or rationality in that. I think one of the, from my point of view, the best bits of information that demonstrates that we do favor the young comes from this fantastic, huge experiment that was conducted at MIT online. And what they were interested in was what driverless cars should do when they're faced with different decisions. So you've got a driverless car here, it's got 5 people in it. If it swerves and hits the wall, it'll kill all the people in the car. If it goes straight on, it'll kill all the people on the level crossing. And it's a development of the old, what's called trolley theory in psychology. So this experiment ran online for several years and got many, many million of answers to different scenarios when different people were in the car, old, young, criminals, a variety of people were in the car and a variety of people were crossing the road. And there is what they found from 40 million decisions in 233 countries, okay? On blue here are the groups we were more likely globally to favor, okay? So young people, pregnant female, doctors. And here on the bottom on the left are those we were more likely to be prepared to sacrifice or kill. Animals and criminals at the bottom, but there's older people there too, okay? So for whatever reason, we're maybe hardwired to think this way, and when we have to make choices about resources to favor the young over the old. Okay, I'll run through now in the final bit of this, just very quickly, one slide each, different forms of ageism in healthcare. The first is what's called internalized ageism, and that's when people say, well, you know, I'm fine, yeah? It's my knee being sore, it's just me getting older, hence perhaps missing treatable rheumatoid, or worse. If a person thinks that way, and many people do, that can obviously delay their presentation or may make them reluctant to take the treatment that we say might help them. The next form of ageism relevant to healthcare I wanted to mention was what you can call formative ageism, and that's the influence of our training and education on the way we think and practice in medicine. Things have improved in the UK since this survey in 2014, but it was quite remarkable then that only about a quarter of medical schools in the UK had any structured teaching in geriatric medicine. And in fact, if you look around the world now, it is worse in many other countries still. In fact, from what I hear of Sri Lanka, you're doing very well. But one of the spin-offs of that is if you're not exposed to geriatric medicine as an undergraduate, you're much less likely to take it on as a postgraduate. And this is perhaps most marked in the USA. I show you here the fill rates for several specialties, cardiovascular disease, almost 100% fill rate. Geriatric medicine, be it in hospital or the community, very low fill rates. And that slide just shows you the same. That's from the US match data. In red there is underfilled geriatric medicine fellowship places, and on the right here is cardiovascular disease. So lots of people don't want to do geriatric medicine. Everybody wants to do cardiovascular disease. And of course, other than ageism, there may be other factors there like income that play into it. Okay, some forms of clinical ageism. The graph here just shows you the percentage of healthcare expenditure in a number of different countries that can be labeled as being spent on prevention. And it's really very low, yeah? 5.1% there for the UK, but lower than that in most places with an average there of 2.8%. So medicine at the moment remains heavily focused on treatment rather than prevention and cure rather than care. That's the way we choose to spend our resources. How does that play into ageism? Well, if you don't focus on prevention in younger life, we'll go on seeing degenerative disease in older life. And when we continue to focus on cure in older life, that could produce longer lives that are of poorer quality. And both of those approaches, if you just pause to think, can be seen as discriminatory against older people, now and in the future. Another form of clinical ageism is the whole idea of taking evidence that's based on populations of people with a single disease. And trials are very, very fond of doing that. And we then extrapolate the information, for example, for the treatment of whether or not you should anticoagulate somebody with atrial fibrillation or whether you should give them chemotherapy and cancer, we take that information and we extrapolate it to the old. And that can actually lead to quite marked over-treatment of older people, again, longer life, but poorer quality, and lots more adverse effects from drug or other treatment. Another form of clinical ageism relates to just simply the denial of treatment or preventative measures. This isn't the best slide that I've chosen to illustrate this, but what it shows is a decline there in the red of the mortality for octogenarians with coronary surgery over time, and an increase in the uptake. And I wanted to show that simply to make the point that when I did some research on coronary disease in older people when I was a good bit younger. And people were very against doing coronary artery bypass grafting in people over the age of 75. But as we got more experience, or surgeons got more experience, the mortality fell, and therefore we could do it. I'm sure you can think of some treatments, maybe dialysis, that is age limited, right? And there are different arguments around that, for example, capacity to benefit. But that, denying treatment on the basis of age is undoubtedly there. As is denying treatment for some screening. So in the UK, there are age-related screening cutoffs. Another example of clinical ageism is lack of involvement of older people in choices about their care. We need to be very careful when we speak to an older person that we take that person's views into account without any pressure from their family. Lots of older people may feel that actually not having the treatment from their perspective is better than actually having the treatment. Again, coming back to the idea of everybody being an individual. And in relation to that, it's very important that we all remember what evidence-based medicine was actually meant to be. Unfortunately, too many people think that evidence-based medicine is the application of information from clinical trials to your practice. That wasn't Sackett's idea. His idea was that evidence-based medicine was the intersection between evidence, your judgment, and what the patient values and wants to do. And if you don't listen to the patient, you won't do what they would prefer you to do. Another example of clinical ageism is deprioritization in the delivery of acute care. This graph here shows you the proportion of patients seen within 4 hours in the UK and UK E&Es in recent years. And the lowest, it's remarkably stratified according to age. These are the over 90s at the bottom here, and this is the youngest cohort up here. So the older you are, the longer you will wait to be seen and processed in A&E in the United Kingdom. And that can lead to, as I've written there, simple problems becoming irremediable. I'm just watching the clock here. I'll probably be a minute over. Another example of clinical ageism has been, and this is improving, the relative exclusion of older people from research of all sorts. The graph here just shows you the changes in the proportions of older people who were included in research in the States when they introduced a specific guideline on that. And whilst there's been an improvement, if you do look at clinical trials and basic science trials as well, there is still a lot of inappropriate exclusion of older people relating either to direct, age-related, or indirect. You can't be in it if you've got, dementia, for example, will exclude you from many trials. And finally, in clinical ageism, I would have elder abuse. I think the best paper on that is in The Lancet, and it estimates extraordinarily that if you consider all these different types of abuse of older people, you'd get a global prevalence of about 16%, which amounts to about 141 million people around the world who are exposed to those different types of abuse. It can be gross, obviously, if it's physical, but it can be subtle. I just ask you all to reflect on the words that you hear in your wards and your clinics that are applied to an older person, many of which are actually quite pejorative. The commonest in the UK would be bed blocker. My final 3 slides relate to what I'd call healthcare system ageism. And the best example of that in the UK is this problem of delayed discharges, where at the moment 13% of NHS beds are occupied by people waiting for social care. They don't want to be in hospital. They don't need to be in hospital. This problem has dominated my entire NHS career, 40 years. And the fact that we've not been able to sort it out, I believe, reflects nothing more than attitudinal problems. We do not see it as important enough, and therefore we haven't been able to sort it. The second form of healthcare system ageism that I want to highlight is the way our healthcare facilities, our hospitals, are designed and operated. One example I've given you is delirium. Delirium is one of the reasons it's very common in hospital is that the environment of the hospital is bewildering for the older person. So we're bringing them in somewhere that's been designed, when you think about it, for younger, fitter patients, and we're not thinking about design of healthcare facilities in terms of what older people need. And finally is the obvious problem in our healthcare systems of access to care. If you have universal coverage of the form that we have in the UK, funded from direct taxation, this is arguably less of a problem, but the information there is from the States, where it's estimated that about 20% of older people find it difficult to pay for their care, because obviously as you get older, multiple different medical problems come together. That's my last slide. I've overrun my time. If you're interested in the subject, and we all should be, have a look at the WHO's various resources on it. And the final point I'd make in conclusion really is that simple one at the top. I hope I've convinced you that ageism is all-pervasive in healthcare. Simply accepting that, talking about it, and thinking about it is a great start. Thanks for your time.
Thank you very much for the insightful talk on ageism. And I cordially invite Dr. Puldisanayake, President CCP, to hand over the token of appreciation and certificate.